Module 5, which is on specialty topics. So, like in the case of Mark, we're going to diagnose and discuss appropriate management of co-occurring substance use and other psychiatric disorders. That's our first objective. So we saw the slide in the first module of the intersection of people with serious substance use disorders and mental illness. So that's 7.9 million who have both. So depression and anxiety. Both of these symptoms are very common at the treatment entry. Frequently, these symptoms may resolve within a few days of stable treatment. Symptoms that persist beyond the acute intoxication and withdrawal can be worthwhile targets for treatment. For example, with SSRIs, so those are the serotonin reuptake inhibitors. The most commonly used are fluoxetine, which is Prozac, Zoloft, which is sertraline, Celexa, which is citalopram, Lexapro, which is S-citalopram. There are many others, but those are the, I would say, the most commonly prescribed SSRIs. And patients with medication-assisted treatment respond to medications for depression and anxiety at rates similar to those without opioid use disorders. But the number 2 point here about the resolution of symptoms is very important because as I work at a residential substance abuse rehab facility, everyone comes in with depressive and anxiety symptoms in the first week or so. And then many resolve and feel better than they've ever felt in a very long time within 2-3 weeks. But sometimes it can take that amount of time before we know if they have an underlying depression or not. Even with family history and history of depression that the client may report, it is worth waiting a bit of time before starting other medications to see if the medication-assisted treatment alone may help, just to avoid having too many medications on board. So the treatment of co-occurring psychiatric disorders. So avoid use of benzodiazepines, as there is a risk of misuse. And then remember there are possible interactions with buprenorphine. And the problem is benzodiazepines frequently get prescribed as first-line treatments for anxiety and depression when they really are not supposed to be. They're supposed to be more short-term medications for acute anxiety, whereas for the ongoing treatment of anxiety and depression, SSRIs and psychotherapy are actually the first-line treatments and obtain the longer rates of remission of these symptoms. So stimulants. Frequently, people with substance use disorders have concurrent attention deficit disorder. And if they are already on stimulants, again, it may be worth checking the prescription drug monitoring system to see if they've been getting stimulant medications from multiple providers, etc. And then if someone is not on ADHD medicines, but there is suspicion of ADHD, then you may want to refer them to a psychiatrist or a primary care provider for further assessment. And it is okay to continue the stimulants if they have been legitimately prescribed by the person's physician and the doses seem to be in reasonable ranges. Again, it's very important to talk to the doctor if there are concerns. So objective 2, I'm going to talk about management of opioid use disorder in the adolescent population. So the New diagnosis of opiate use disorder in youth has been rising along with the general population as well. Still relatively low in the under 18 crowd, but it seems once they're out of school and on their own, that's when the risk goes up. So this slide shows the proportion of youth receiving treatment within 6 months of diagnosis. So over the last 16 to 18 years, the proportion of youth getting medication has increased for opiate use disorders. So the Data 2000 authorizes the treatment of individuals ages 16 and older. So buprenorphine is approved for individuals over 16 years of age, and methadone is only approved for individuals over 18 years of age. So the 42 CFR 812 offers an exception for methadone in patients aged 16 and 17 with a documented history of at least 2 prior unsuccessful withdrawal management attempts and have parental consent. The age of consent varies from state to state, so you'll need to check with your state laws to be sure. Now, for pregnancy, all adolescent females should be assessed for pregnancy prior to starting buprenorphine to discuss all the different treatment options. The American Academy of Pediatrics recommends that pediatricians consider offering medication-assisted treatment to their adolescent and young adult populations with severe opioid use disorders, or to discuss referrals to other providers for this service. The FDA-approved medications are the big 3 that we've discussed already. And naltrexone ER is approved for patients over 18 years of age. Now, the psychosocial treatment options available are family intervention approaches, vocational support, and then behavioral interventions as well. Okay. So pregnancy. This is also a big problem, the use of opiates during pregnancy. So this is the epidemiology. 21,000 pregnant women aged 15 through to 44 misused opioids in the last month. So the prevalence of opioid use among women who gave birth increased in the U.S. from 1.19 to 5.63 per 1,000 hospital births per year between the year 2000 and 2009. The American College of Obstetrics and Gynecologists and ASAM recommends screening for substance use as part of comprehensive obstetric care and should be done at the first prenatal visit. Recommend using SBIRT, which is the screening and brief intervention and referral to treatment, and screening tools. The 4 Ps, parents, partners, past and present, NIDA Quick Screen, and CRAFT are helpful screening tools for this population. CRAFT is typically made for adolescents, and that's why there's that note for women 26 years of age or younger. So this is buprenorphine versus methadone for pregnant patients with opioid use disorder. Again, the availability of the treatment options plus the patient preference should be considered. The buprenorphine model product is as effective as methadone, same rates of adverse effects as methadone. Whoops. There are fewer drug interactions, less frequent neonatal abstinence syndromes and milder abstinence symptoms in neonates, decreased morphine dose required in the neonates as well to treat these abstinence syndromes, significantly shorter hospital stay, significantly shorter duration of treatment. Methadone programs may provide more structure, so may be better for certain patients with more unstable situations. Now it says there's decreased risk of diversion and there's more long-term data on outcomes. Now methadone treatment for pregnancy used to be the first line treatment, and it's still commonly used for pregnant women with opioid use disorder. And it may be slightly better at blocking cravings than the buprenorphine. And as the pregnancy progresses, especially in the second and third trimester, the doses may need to be increased due to the increased metabolism and blood volume. And with increased gestational age, the plasma levels of methadone progressively decrease and the clearance increases. And so that's why sometimes the dose may need to be split in order to provide the coverage through the day. So the half-life of methadone, which is typically very long, it's an average of 22 to 24 hours in non-pregnant women, goes down to 8.1 hours in pregnant women. And so along with the increased dose, you may need to split the dose into two 12-hour doses. So this is the mother study. Methadone treatment versus buprenorphine for, this is total dose of morphine, is the first column. Mean hospital stay is lower with buprenorphine. And the mean duration of neonatal abstinence syndrome, again, lower with buprenorphine. So use of buprenorphine with or without naloxone in the pregnant patient. During pregnancy, no significant dose increases are needed, although you may need to split the dose in the third trimester. Postpartum, you can gradually transition back down to the original pre-pregnancy dose, and the mother can continue breastfeeding, which is good. And the combo drug may be safe during pregnancy. However, it is recommended that the mono drug be used in the pregnant opioid-dependent women because of the risk of precipitated withdrawal if someone tries to shoot up with the combo drug. And we want to avoid any sort of withdrawal when a woman is pregnant. So neonatal abstinence syndrome. There's been an increasing incidence of neonatal abstinence syndrome. And the incidence of newborns with NAS is between 70 and 95%, with 50% of infants with NAS needing treatment. And the symptoms are irritability, fever, diarrhea, hyperreflexia, and seizure. Can begin around 24 to 72 hours after birth, with peak symptoms at 3 to 4 days, and this can continue up to 1 week. The complications of NAS, so it's associated with untreated maternal opioid use disorder And there's an increased risk of placental abruption, preterm labor, obstetric complications, and fetal death if someone with opioid use disorder is not treated during pregnancy. So the management of NAS, medications. Opioid therapy is the preferred first-line intervention. So the medications that are used to treat the babies are either morphine or methadone. Clonidine can be used, but it does not really help with the irritability. The non-pharmacologic approaches, rooming in with the mom can result in decreased NAS, length of stay, and cost. So that's when the infant is brought to the mother right away and staying in the room as opposed to being taken back to the nursery. Breastfeeding is actually not contraindicated in mothers on medication-assisted therapy. The amounts of methadone or buprenorphine in the breast milk are actually insufficient to prevent symptoms of NAS. The levels in the human milk are low, so it's less than 3% for methadone and 2.4% for buprenorphine, so it's similar. And NAS can occur after abrupt discontinuation of methadone. So now we're going to discuss strategies for managing acute, perioperative, and chronic pain for patients taking buprenorphine. So acute pain management and buprenorphine maintain patients. So there are different approaches. First, you can try non-opioid analgesics, such as ketorolac or NSAIDs, or you could continue the same buprenorphine maintenance dose but add analgesics, increase buprenorphine dose with more frequent supplemental doses of sublingual buprenorphine, stop buprenorphine and initiate full agonist therapy, dose to effect, so dose to address the pain control. So these are different approaches that are available. So perioperative management. In general, patients do fear being mistreated if they reveal their addiction history. Providers fear being misled by patients as well. And there's a lack of consensus in the field about how to actually treat people with addiction problems perioperatively. Pre-op, so we need to do the multi-party consent and coordination of care with the different providers. And if the patient is already on a partial agonist, the last buprenorphine maintenance dose should be 24 hours prior to surgery. And you may need to utilize the short-acting opiates as needed. And again, higher dosing of the short-acting opiates may be required. So post-op for patients already on buprenorphine. The options are continue on full agonist treatment and then transition to partial agonist, or continue the partial agonist treatment. So things to consider. Consider using extended release long-acting with intermediate release short-acting for breakthrough pain. The discussion about risk of relapse needs to be had, and then medication security. So if you and the patient decide that you want to just continue with the partial agonist treatment, then you might want to consider more frequent dosing. Might have to increase the total dose for a duration of time, and have a clear, detailed discussion ahead of time with the patient about returning to the baseline dosing with a specified timeline so that the patient can anticipate how things are going to happen. So acute pain management for patients on naltrexone. So for those with mild pain, the non-opioid analgesics, such as the NSAIDs, are the first option. Now, if somebody's getting elective surgery, you have to make a plan. So oral naltrexone must be discontinued at least 72 hours before the surgery. And then extended release naltrexone, that's the shot. Basically, they would have to be off the shot, or after they get the shot, it's the 4 weeks after that then they could get the elective surgery. Because at that point, the naltrexone should be out of their system. And if there is an emergency situation, such as there was an accident or something like that, you might want to consider regional anesthesia or sedation, conscious sedation, or general anesthesia. So high potency opiates like fentanyl can override the blockade, so that's another consideration as well. So acute pain management for patients currently on methadone. So consult a pain specialist. It's interesting that it just mentions that in this particular slide, because I think in all the prior situations, consulting a pain specialist is a good idea. But again, you may need higher doses of methadone and higher doses of additional full agonists until you achieve the pain control needed, due to the tolerance that develops with the daily methadone dosing. And chronic pain patients, again, consulting with a pain specialist is helpful. Multidisciplinary approach is also very helpful. Trying non-opioid and adjuvant analgesics, and consider non-pharmacological therapies. So this would include things like acupuncture that can also help with pain control. So number 5, can discuss considerations affecting use of medication-assisted treatment in older patients. So the general population of older adults is growing. Globally, there's 516 million to 1.53 billion from 2009 to 2050 is what's projected. In the U.S., 1 in 5 U.S. residents will be age 65 by the year 2030. Substance use disorders in older adults as of 2014 was 1 million individuals, 978,000 with alcohol use disorder, 161,000 with illicit drug use disorder, and this is expected to increase to 5.7 million individuals by 2020. So this is both of these disorders combined. And there's not a whole lot of high quality research available for prescription drug misuse in older adults. So last year, the prevalence of non-medical use of opioids was around 1.4% in the older adult population. So some unique features of working with older adults. So the physiologic changes, there's decreased metabolism of medications, increased elimination time. Frequently, the geriatric population, there is polypharmacy for multiple medical conditions. There can be multiple comorbidities, including cognitive decline. And there's a higher prevalence of pain in general in older adults. So 25 to 50% of those living in communities, dwellings have pain, 70% of those living in nursing homes, and 80% of those living in long-term care. So some risks, self-poisoning has been reported as a frequent mechanism of suicide. So older adults, some more treatment considerations. The evaluations, conduct a thorough screening, of course, and assisting patients with cognitive impairments, assess for suicidality. Some of this is the same as with other populations as well. So some medication recommendations. Buprenorphine may be a good first-line medication for the treatment of pain. And especially as the elderly may be more susceptible to the respiratory depression that can happen through sedating medications. Start low and go slow. This is a rule of thumb in working with the geriatric population. Hepatic metabolism is slower in older adults, so the maintenance doses you may need much lower than those that used in younger patients. So methadone is a lot riskier due to the multiple medications that many older adults are on. So there's that higher potential for drug-drug interactions with methadone. Again, QT prolongation, and especially with other drugs that may prolong the QT interval, puts the person at risk for cardiac issues as well as sudden death. And there's a higher risk of overdose for methadone. Okay, so point 6. Now we're going to identify some potential interactions of retroviral medications with buprenorphine. So in HIV-positive patients, CYP3A4 is the primary enzyme that's involved in the metabolism of both methadone and buprenorphine. And many antiretrovirals can affect buprenorphine or methadone levels, and in some cases, it can be the other way around. There are markedly fewer drug-drug interactions with buprenorphine and antiretrovirals as compared with methadone, and with little to no interactions with naltrexone. So naltrexone is the safest. The next is buprenorphine, and methadone, as we've talked about, due to the drug interactions, is riskier. And always consider referral to specialized HIV treatment programs and services if they are available. And point 7 in this module is how do liver and kidney impairments affect dosing of buprenorphine. So in patients with renal failure, using buprenorphine is no problem. There's no significant difference in kinetics of buprenorphine in patients with renal failure versus healthy controls. There are no side effects typically in patients with renal failure. And both buprenorphine and methadone can be prescribed to patients undergoing dialysis. So in patients with compromised hepatic functioning, so those folks with maybe advanced stages of Hep C or cirrhosis due to history of alcohol use, those folks may have reduced metabolism of buprenorphine, so there will be higher blood levels of the medication. There's no specific hepatotoxicity demonstrated with either methadone or buprenorphine, but basically we need to watch the levels, basically observe for side effects with the higher doses, and again may need to lower the doses a bit in folks with liver problems. And so monitor them closely, monitor the LFTs on a periodic basis. So hepatitis and office-based treatment. So both buprenorphine and methadone are contraindicated in patients with acute hepatitis, but not necessarily contraindicated in patients with mildly elevated liver enzymes. So if they have moderately elevated levels, so 3 times greater than the upper limit of normal, they should be monitored. Acute active hepatitis should be evaluated and treated. And the reason for the markedly elevated liver enzyme function tests should be determined and treated. So in summary, 40% of adults with substance use disorder have co-occurring psychiatric disorders, and diagnosis and treatment of these mental health issues can have a positive effect on the opioid use disorder as well. So these are for the folks who are self-medicating depression, anxiety, PTSD with their opiate use. If you treat the underlying mental health issue, the opioid use disorder can get better as well. Although buprenorphine is approved for individuals over 16 and methadone is approved for individuals 18 years of age, naltrexone ER can be considered in combination with psychosocial treatment for adolescents with opioid use disorder. And methadone has historically been considered the first-line treatment for opioid use disorder. However, the evidence is showing that there's equal efficacy with buprenorphine, the monodrug, and it's very well tolerated and effective with benefits for the newborn. So for perioperative pain management, coordination is really required with the surgical team. So this will need to be probably discussed on a case-by-case basis with the person's individual needs as well. Buprenorphine is a good frontline treatment for older adults with opioid use disorder, as they are on multiple medications, and methadone itself has more drug-drug interactions than buprenorphine, so buprenorphine is much safer. Also with retrovirals, same issue as well, less interaction with buprenorphine than with methadone. And both buprenorphine and methadone are okay to use in patients with renal failure. Acute hepatitis. In acute hepatitis, methadone and buprenorphine are not recommended until after the treatment of the hepatitis. But if the liver enzymes are only mildly elevated, treatment with either one can continue. Okay, here are the references. Okay, so here's an appendix. Shows the interaction of antiretroviral agents with methadone and buprenorphine. I'm not going to go through these individually, but basically this chart shows some of the effects with both of these medications, the methadone and buprenorphine. Okay. Any questions with this module?